Hello and greetings to our lovely students out there. RFA is back again with Know Your Exam series with EFOG-2 Osce. Warm welcome to all of you out there. Is my voice audible and is it clear to all of you out there? Hi, can you all hear me? Yes, the voice is clear? All right. Hello, Chin. Hi, Camelia. How are you guys doing? Students are desperate to listen to your voices.
Hello from my side. My name is Chin, and beside me, Dr. Camelia.
Hello, Camelia.
Hello.
How are you doing?
Hello, we're good.
That's lovely. Students are so excited to listen to us today. They wanted the introduction. Lots of queries coming up in the study group, Chin and Camelia, that ma'am. We have done MRCOG. Is it okay that we do the same preparation? We have done MRCPI. Is it the same way we are going to just take forward this OSCE as well? Hello, Humaira. Thank you very much, my dear. I hope you're fine. Lots of students. Hello, Ala. Thank you very much. So we all welcome you on behalf of the entire team of RFA tutors. I hope you all are doing great. And this is the most awaited introduction to your exam series for the OSCE preparation. All right. So why are we meeting today? I know you people have got lots of questions, lots of queries, which we are going to address today. We will give you the glimpse of how the preparation is different and how the preparation has to be focused, how we can prepare efficiently, and how we are going to make it in one go. But before that, because we are going to start the course and we are going to start the sessions focused to the exam pattern, you people need to understand what this OSCE is all about. We very well know that you people have a background knowledge because many of you in our study group, you people are having some sort of an information regarding the Royal College of Obstetricians and Gynecology in the United Kingdom. You do have the Irish exam information in the background as well. But how we are going to make it different, how the pattern is different, what the exam contains, Chen is going to tell us in detail that what is the method of assessment, how the previous OSCE and the current OSCE is going to be compared. Over to you, Chen, please. Students want to hear that how this European Board College and OSCE is different and what does it contain?
Yeah, thank you, Dr. Sidra Ali. So as you all know, the Part 2 examination OSCE, EFOG-EBCOG, it's slightly different, or they are branded differently from your MRCOG Part 3 or even your RCPI clinical examination OSCE component. So as what Dr. Sidra Ali said, we are here today to tell you what are the differences, and at the very end we'll pinpoint and highlight to you what are the differences between all the three fellowship or the membership exam, we call it. So as you all know, this Part 2 examination OSCE, or the objective structured clinical examination, it's basically a performance-based testing to measure the clinical competencies of each candidates, okay? And as you can see on the front of your slide, that it's been highlighted that the component that's being tested or evaluated is the history taking, the technical skills, the communication, teamwork, integration knowledge into the clinical problem solving, and evaluation of the clinical relevance of the scientific article, which we will all cover from cover to cover during the whole module or the course. And the objective, of course, is again to assess the candidate exactly the very same station, similar station, you have a similar marking scheme so that they will not be biased in terms of marking. There will be no discrepancy in terms of scoring the candidate during the examination. And it is a very structured examination because it has very specific tasks, and therefore during the course or during the module, we will be emphasizing on how important it is to read the instruction very carefully that is being provided to you, and because you have the privilege of 2 minutes before entering the actual station or performing the task. Okay, and of course, in the clinical examination part of the OSCE examination, that the theoretical knowledge will be tested, and you will be expected to answer some sets of questions from the examiner at the end of the station to be helping you to score in the scorecard. Okay, next. So, like I said, you have 10 stations, but 9 active stations, and each station will take 10 minutes, okay? And you have 2 minutes of reading time before you enter the actual 10 station, before your clock ticks off. And the marks, or the OSCE, is being marked by examiner at every station. And I'll go through Dr. Sidra Ali will be going through the components and the stations with you later on briefly. So just kind of important things to remember, dates to remember. One of it is the deadline, which is the 10th of September. So you have about 2.5 months before the deadline for the applications. And the exam will take place on the 19th and 20th of November over course of 2 days. And I would say, fortunately, this time we will be doing a face-to-face examination for the very first time, because we have been denied that sort of privilege of traveling due to the pandemic, unprecedented event of the pandemic. So Lisbon will be the venue of the examination, and the fee is €700. But for those who are non-European Union residents who are staying outside European EU, you will have to pay extra €100 on top of that. Okay.
All right. So, Chin, we have been emphasizing in the study group that everybody has registered. Those seats like MRCP, OSCE, or MRCUG, OSCE, it's not a trouble here in EFCOG. They generally get the seats because the candidates are less. But still, I would like to ask that I hope you all have booked. Humaira, Ala, my dear, Ahmed Kamal, I hope you people have sent all the details and the applications, because there should not be a delay. The seats are not fixed. They're going to entertain, but I definitely want all the core students who are aiming, who passed EFCOG 1 with us in the May exam. We definitely want you to appear, because the sooner you do, definitely the applied clinical knowledge, the theory part is fresh. So you should not miss out. Many students were messaging Chin that, ma'am, this time it's not online, we need to travel. So if at all there is no grave problem, I would definitely suggest taking in one go, because you're in a continuity of studying. When there's a break between the written part and the OSCE part, definitely there is some sort of a foggy knowledge for the background of the written as well. So you need to give an extra effort to revise the curriculum. Chin, would you agree?
Yes, definitely. And not only from the knowledge point of view, I will be quite cautious about getting the approval fast from the examiner, exam secretariat, so that you can apply for your visa, because the letter will be provided by the college, so that you can apply your visa early, so that there's no stress at the very last few weeks.
Exactly. And in the study group, Chin had been guiding if somebody has got any sort of a problem in terms of the visa, any sort of a suggestion needed, please do get connected. All right, Humaira is waiting for approval. Archana Anand has booked. That's lovely. Tyra has booked. That's great. So I want you all, if anybody has not done, please note down the dates. Don't wait for the last date, that is the deadline. The sooner you do, the better it is, so that you're focused and you do the preparation with ease. All right. Yes, Chin, how was the exam last year?
So what's the 2021 exam like, and what's going to be new for us? So that would be kind of a challenge for all of us again. So in the last exam in 2021, you had two circuits of OSCE, namely OSCE A and OSCE Circuit B. So each OSCE circuit has 3 different stations and different tasks, I should say. So the first circuit will involve actor or actresses in the station itself, and you'll be like, for example, one of it is history taking and summarizing the content of the handover to another colleague, as you would in real life. And the second task was also about explaining a certain scenarios and interpretation of some laboratory examination or scan reports. And then you'll be discussing that, a plan with the patient actor, and breaking bad news, which Dr. Sidra Ali is very good in taking you through this station. And I'm sure you would ace it very well for this one. For the second circuit, in the past, back in 2021, we also have what is very slightly different from MRCOG and MRCPI, where you are given a scientific article, and within the 10-minute span, you have to discuss the abstract and summarizing the scientific article, which we will go through in detail during the course as well. And of course, reporting the incidents, which we will be covering quite thoroughly in the course as well. I will be doing, and I'll be taking this session with all of you. The short presentation, fortunately or unfortunately, has been removed from the exam components. So maybe that may be a good thing from the exam point of view. So I'll get back to
all right. So what's the difference, Chin? Last time students had all this online preparation and they had all these 6 stations. This time, friends and family, we need to be a little focused. And here there are certain things where emphasis is more on that of the article, on that of the clinical governance aspect. I won't say that MRCOG doesn't rely upon that or they don't emphasize on this, but here specific stations have been marked. For example, when they say station number 1, that's a preparation that you're going to read an article, and in the station number 2, as Chin has mentioned earlier, that you've got 10 stations, but out of that, there are 9 active and 1 preparatory station where you're going to read, make yourself prepare, and get ready for the evaluation of the article. Now, the basic technical skills, they are divided into 2 different parts in 2 stations, like an obstetric and the gynecology. And the all the details Camelia is going to cover thoroughly in this. She will tell you exactly in the basic technical skills what questions they're coming, what do they expect from us, what are those topics which you need to be 100% in your preparation confident at, which would make you prepared for any sort of a new topic as well. So all the details she's going to cover in detail. We're just going to have a glimpse of that in a bit. Now, the complex technical skills, again, station number 5 and station number 6, that's been divided again in the obstetric and the gynecology topics. And they involve the leadership, they involve the communication with the colleagues, and they involve all those emergencies, obstetric emergencies. The list we'll provide you just in a bit. And in the details of the course, in the schedule, we'll provide you that these stations you need to cover, and this is going to be the upcoming session so that you exactly know that this is from the complex technical skills. We have divided the sessions according to the themes because it's not module-wise in MRCOG. It's not the long case or the circuit as in MRCPI. We need to follow the format. We need to be good at exactly the exam pattern. Now, the station number 6, knowledge integration and decision making. Again, there's going to be an obstetric case and there's going to be a gynecology case. Last time they tested upon heavy menstrual bleed. So the cases from the gynecology and the obstetrics, it's simple in terms of knowing the history, examination, investigation, and treatment. I'll just tell you that how exactly we are going to cover it up. And the station number 9 and 10, again, the communication skills, where the breaking bad news is super important. No exam is complete without breaking bad news. May that be MRCOG, OSCE, may that be MRCP, OSCE, may that be EFOG-EBCOG-2. It's always coming, like last time they just gave the molar pregnancy. So these components, what I want to tell all of you is that exam is doable. Exam preparation is same like obs and gynae, but the pattern, the format, and the certain things where the emphasis has to be more, we need to understand. As Chin has described to all of you out there, that we have got 10 minutes for each station, and we have got 2 minutes of reading time to get prepared and organize ourselves to speak. So the basic technical skills, the complex technical skills, the breaking bad news, appraisal of the research article, which students are so scared of, and Chin is master in. His slides, his algorithms are going to be sufficient. He would give you just the lines which you have to cram up for any research article to speak up, and you just need to present that and put in certain paragraphs which are going to be from that article. The beginning, the middle part, the ending, everything is going to be easy once you understand that how to appraise a research article. And the shared decision stations, I'm going to tell you that how to negotiate, how to make your patient comfortable, how to talk with ease, and what are those words which are going to impress the examiner and of course your patient as well. What is the exam marking criteria, Chin? How is it different from others, and what is the examiner's expectation?
Sure. So basically every station is being scored from 0 to 20. So that means naturally you have 9 active stations. So the total points in total is 180 points. And of course, that will be converted into percentages over 100%, and that will be rounded off to the nearest 1 decimal point, nearest integer. So again, there is no specific pass mark. And of course, the pass mark will be determined by the median score of the candidate that is considered as a borderline examined by the examiner. Yeah. So again, the result will be published 20 days approximately after the exam date. And again, the 20 points will be spread out in various different skills of each OSCE stations.
Yeah. So the exam marking, as Jen has discussed, we need to understand this so that from day one, we are focused. As I've told you, the theme assignment is very important. Today, we are together to understand that how the preparation is going to be different. So our course structure would not be like early pregnancy, would not be like maternal medicine, would not be like antenatal care, like you do with me in the MRCT Part 3, or you do with us in the MRC Pair OSCE, like where we cover different modules. Here, the things are going to be different. We are going to structure the course according to the assignment, theme assignment that's been provided, the format by the college. So we will take sessions on knowledge integration and decision making. I'm going to take that. I'm going to take sessions for communication skills, breaking bad news, specifically around 3 sessions. Basic technical skills, Camelia is going to take her complete structured explanation regarding the basic technical skills. 3 to 4 sessions would be there, complex technical skills also, and appraisal of the research article. So the format of the exam would be followed for the format of the course as well. Just to know that no matter you have done OSCE earlier for MRCOG or MRCPI, you need to change your pattern, study pattern. You need to be focused at what are they expecting us to know and what is going to be the exam pattern. We have to prepare ourselves accordingly for that, right? So when we come to communication skills with knowledge integration, I'm going to give you all the exam stations that have been discussed in the last few years. Basically, for the breaking bad news, we'll do the basic ones, which are very, very important, like a cancer, malignant lesion, pre-malignant lesions, like intrauterine fetal death, a very difficult, a very challenging station coming up in exam. Lethal fetal anomalies, specifically anencephaly, coming in exam very frequently. Non-lethal fetal anomalies as breaking bad news. Male subfertility with a report showing azoospermia. Early pregnancy, breaking bad news like ectopic pregnancy, molar pregnancy. That was just the recent exam station. Premature ovarian failure is also an exam tested station for the EFOG. So breaking bad news, in a booking investigation, patient turns out to be HIV positive. I would try to coach you in a way that if the stations that had been mentioned on the website as an example, or they have been tested for the previous exams, we are going to cover it up. But despite that, you should know the skill. You should know the art of breaking bad news. You should be knowing that we make an introduction with no smile, with an introduction with a seriousness out there, and then you make an agenda and purpose. For example, if you have to start, you won't be starting like a clinic case. You won't be starting with a gesture or greeting, which would be cheerful. You should be knowing it's a breaking bad news, and gradually I have to bring my patient to understand. And while breaking the bad news, she should understand, and there should be a sign posting. She understands that something serious or something as a bad news is coming up ahead. So the biggest mistake students they make for the breaking bad news station to begin with is that they start with hello or hi with a big cheerful sound. For example, if Ahmed enters and say, hi, I'm Ahmed, one of the doctors in the clinic today. So this is one way of greeting that is acceptable in a clinic, antenatal care, or a maternal medicine where something is not bothering. But when you have to start a breaking bad news station, you always have a very serious, a very calm, a very composed voice. Hello, I'm Dr. Ahmed, one of the doctors in the clinic today. May I confirm your name and age? Is it okay I call you Anne? I've gathered from your case notes that you're here today to discuss about your ultrasound, which you recently had. Is that right? Can I ask you questions to know more about you, Anne? and then we can discuss about the ultrasound report. Would that be okay? See, there's a difference in voice. There's a difference, and exactly examiner is testing you upon your communication skills when it comes to the breaking bad news, because it tests empathy. It tests that how good you are and how well the patient is in absorbing that news, right? Whenever the breaking bad news is started, you warn the patient. That signposting means that you are making the patient ready. I can say that you're here alone today. Would you like somebody to be with you? Once the first warning or the signposting is done, you make a second signposting because the patient is alert. I'm afraid that I have a difficult news to discuss with you today. Or I'm afraid that I don't have a good news to discuss with you today. So these two signposting, they contain score. You are being analyzed on these steps. Any of the student, if is abrupt, is quick, and is spontaneous without doing the signposting, you people would have difficulty in understanding. Difficulty in understanding that patient is not getting the gist of that signposting. And if you're abruptly telling the diagnosis, then the score is deducted. Right? And after second signposting, you give the results. You give the results straight after the second signposting. May that be a malignancy, may that be any sad report in terms of azoospermia, or may that be an intrauterine fetal death. I will give you lines. You're going to practice with me that this is how we are going to break certain bad news. The signposting would remain the same, but the results which we have to tell has to be in simple, straightforward, and above all, open and honest. This is the biggest difficulty which is being faced by students. For example, it's an intrauterine fetal death, and students, they get like fearful, saying, I'm sorry, we could not appreciate the baby heartbeat. So this statement, do you guys think is clear? It's not clear. That can show some sort of a defect in the ultrasound machine, or for that matter, expertise. Do you people understand, Sheila? Yeah. So you have to be very clear, open and honest, and very clear sentence. I'm afraid that the baby heartbeat could not be seen and the baby is dead. So the words have to be clear. If it's a cancer, say it's a cancer. Don't say that there's something serious. We don't have to hide. This is the criteria you people need to understand. We don't have to hide. We don't have to make it sugar-coated, but yes, empathy has to be there. We need to be very empathetic in that tone so that it is a clear breaking bad news. And after saying that, always give a pause. Here again, students, because they're nervous, they just rush through the station. For example, they say that the baby is no more or the baby is dead. And immediately after that, they would be just starting with the management without giving a pause. Again, here, the marks they get detected. We have to be very clear in this that the grief reaction contains score. So to recap, your first signposting contains scores, your second signposting contains score, telling the exact honest report that contains score, and then giving time, pause for grief reaction that contains score. How do we do that? I always tell students that once you tell the diagnosis, speak in heart. 1, 2, 3. I can see, Anne, that it has come as a shock to you. Me and my team of doctors are here to support you in this situation. So you need to understand that where pause is actually giving you score, where speaking extra can actually reduce your score. This is what communication and practice is all about. And after showing empathy, if she's weeping, you may offer wipes, you may offer a glass of water. And you tell her that if you give me an opportunity, I can tell you that what treatment options we have for you. And we are going to connect you to the counselor for support as well. So then you have to take control of the consultation. Her state is understandable, but you have to take forward the station because this is your exam. That is an art. You have to lead the role player. You have to settle the role player, and that contains score. and then you come to a mutually agreeable plan, and then you close the station with, again, empathetic words that will be different with different breaking bad news. So once you'll start doing the breaking bad news with me, you people will become master. You people will correct each other also that, okay, this is the time where you need to take a breath. You need to take like 3-second pause. This is the time signposting was a little louder. It had to be matching to the role player. And the second signposting was a little faster. So breaking bad news is actually your communication with the patient is being tested. So I'm sure with the course topics which we are going to cover, you all would be master in this, but definitely would require your input in terms of practice. More practice is going to make you fluent and make you perfect in this breaking bad news. You need to understand then second part in the communication with the patient is going to be your different cases from early pregnancy, from antenatal care, from maternal medicine, from surgical and post-operative, from labor and delivery, from postpartum, from teaching on the mannequin can be there for any junior. It can be a urogynecology station, subfertility, oncology, or your sexual and reproductive health, where you will have the disease or condition of the patient. You will be asked in the task to take history and have a shared management plan. For example, last time heavy menstrual bleed was there. So you have to discuss about the intrauterine system, that we have got a hormone coil. You need to discuss the pros and cons of that. Here, I will have separate sessions for that. We'll try to cover all the exam tested stations first, and definitely will make you know that how history taking of urogyne is different from gyne from subfertility, and how the history taking is different in oncology. Because it is on-site exam, you should be knowing about the examination things which you have to speak, which Camelia is going to guide you further in the basic skills. The investigation, telling the report in communication is very important. How to basically make a treatment plan. Knowing the treatment plan is, I'm 100% sure about my students that you all know. Telling the treatment plan correctly without bombardment of the information, without having a scattered gun approach, is a challenge which we need to learn with practice in this Osce. And above all, you say that it is the hormone coil best for this condition, and the patient says, I'm not happy to have something inside the womb. Here comes your communication skills of negotiating with the patient. Here comes our practice, that how we have to make patient our party, how we have to convince the patient for what is best, and how we have to learn to listen to the patient to negotiate and come to the correct option. This is going to be my task, and all communication stuff we are going to do together. You will feel the change. Practice is the only solution. We are going to come up with a plan where the practice is going to be more, and you people will get all the details and the schedule in the study group after this in the WhatsApp. Thank you very much. All right, so I hope you people are clear about the communication, that what are you going to be tested for. Basic technical skills is another thing for which we are getting so much of queries, and Camelia is going to guide you that what do we expect in obstetrics and gynecology. Hello, Camelia, over to you.
Hi, Dr. Sia. Thank you so much. So yeah, as we mentioned earlier, we are going to have students are going to have 2 stations in the exam that will involve basic technical skills, the obstetric part and the gynecological part. So in terms of the skills that relate to obstetrics, these are only a few examples of what topics I will include in my sessions. So obstetric abdominal examination, instrumental delivery, cesarean section, breech delivery, and ECV. We can go further, yeah. And for the gynae part, I also included a few examples of the topics that I will be covering. So such as bimanual pelvic examination, speculum examination, laparoscopy, hysteroscopy, abdominal and vaginal hysterectomy. And as you can see, they are all topics that I'm sure all of the students are familiar with from the clinical practice. It's just a matter of going through the session and practicing how we are going to go step by step in each topic, and how we are going to communicate our findings. So a glimpse or an example of such a station, as I mentioned, would be obstetric examination. So yeah, we'll go through next slide. These are just the steps. We are going to go through the steps and practice each and one of them, and also communicating the findings of your examination with the examiner is going to be important. Yeah, next slide. Yeah. Well, these are just illustrations of the steps and how they are going to be.
This one is very important. They always need
Yes.
to know about this and what's the size, and examiner always expects Camellia, right?
Yes.
Yeah.
Yes.
Okay, right. So basically, how do we tell the finding? That's an art.
So exactly, these are the steps, as I was mentioning. These were just the steps that we have to perform in clinical practice, and then what is also important and relevant in the sessions is how we are going to communicate the findings to the examiner. So I am going to go through each one of them. For example, for inspection, palpation, or auscultation, we are going to practice with each student how to convey these findings.
Yeah, because if you're going to do the examination and if you're fumbling and you're not able to tell that correctly, that definitely is going to reduce the score. So we have to be very good in actually telling the findings.
Yes.
So that's very important. Yeah.
So this is just an example in how you are going to describe, for example, for your obstetric examination, this is a singleton pregnancy, longitudinal light, cephalic presentation, head not engaged, fetus clinically large for size, Likert volume clinically normal, and the fetal heart is normal. So just to organize the information and the findings from the clinical examination.
Yeah, that's perfect. And this is what they wanted to know.
Exactly.
So all the technical skills and the communication, applied clinical knowledge and patient safety is being tested, right, Camellia?
Yes.
Yeah. Okay. So about these skills, what should be in their mind? It's about practice, right?
Yes.
Okay, that's perfect. All right. Okay, so the basic technical skills she's going to take over, and perfectly she'll tell you about all those examination, the transvaginal scans, and all the details. Now, not knowing the details, it's not enough. Basically, telling them in detail and how to speak up in words to give the idea whatever you've observed in the patient. That's very important. That's what we are going to coach you for, and we'll try to make you master in. Thank you so much, Camellia. Thank you.
Thank you, Rosita.
What about the complex and the teamwork?
So we'll come to a very important themes in the examination, which is the complex decision making, and also teamwork, working in a team, and how to communicate these results or certain investigation to your colleague. So as we know, there are two stations that involve complex and teamwork technical skill. One is the obstetric, obviously, and the second one is the gynecology. So in obstetric, we will be covering topics like eclampsia, APH, fetal growth restriction, multiple pregnancy, and preeclampsia. Going on to the list, so the list can be quite non-exhaustive. So the autoimmune disorder, obesity, and all medical disorders in pregnancy, postpartum hemorrhage, sepsis, and thromboembolism.
I just have few are very important, Jen. If you remember, like PPH, that's been like all the exams, it's been super important, all the OSCEs, antepartum hemorrhage, the bleeding is like very important. And the chances like 70 to 80% that they get like any sort of a bleeding in terms of antepartum or postpartum hemorrhage, yeah?
Yeah, that's right. So I suppose every European trainee will be expected to know the APH and PPH and keep out their finger, basically.
Correct. Yeah.
So for the gynecology point of view, of course, things that is a must know: ectopic pregnancy, gestational trophoblastic disease, early pregnancy, which you will be doing very thoroughly with Dr. Sidra Ali in terms of the Breaking Bad News team assignment. Emergency gynecology like ovarian torsion, PID, and acute abdomen, and also the subfertility component.
Yeah.
So just to get you kind of a flavor of the complex teamwork technical skill station. So I'm just going to read this out loud to everyone. So Mrs. Nora Korenopoulos, who is a 40 years old, IVF pregnancy, para note at 28 weeks, soak her babe with 300 ml of painless fresh blood per vaginum. So in 10 minutes, so like I said, this sort of instruction will be available to you outside the station, and you have 2 minutes to read the station before you enter the actual station of a 10 minutes. So in 10 minutes, you're expected to take a targeted focus history from this patient and to include today's event and the patient's background. And again, you will be marked according to the skill domains, which is patient safety that's being checked. That's very important. For example, they're checking on you whether she will accept blood transfusion if it's needed. What is the blood ABO rhesus blood group? Because you will be giving her anti-D immunoglobulin if it's required or if it's appropriate in this case. Communicating with patient family. So if, let's say, you do need to admit this patient as an inpatient for observation for some reason, then you have to check what is the social background history, whether she have any other children at home who are minding her children, and if someone is taking care of her children or her social issues at home, who is living nearby, or what's the proximity from where she's living. Like if her parents are living down the road, if the parents are living in the same area as her. So that sort of thing that you will be marked on. Communicating with the colleagues, of course, how you're going to convey the history or how you're summarizing this history to the examiner, and information gathering. That's of course quite obvious from the targeted history and applied clinical knowledge.
And management.
Yeah. So this is kind of like a kind of a structure that you have to put in the mind when you go into the station, tackling the task basically. So again, like I said, from the very first few slides, I said, read the instruction very carefully. So the initial management usually will require you to ask for history, examination, and investigation. So in terms of history, it has to be very focused in relation to her chief complaint. Okay, so it's about the antepartum hemorrhage that she has come to you or she has presented to you with today. It's not about, about her urinary tract infection symptoms or other things that are not very relevant in this scenario, because you only have the privilege of 10 minutes to elicit all the pertinent history and then regurgitate it back to the examiner in order for you to score the point. And also review notes for comorbidities. That's very important because some amounts of safety check is there that will be marked accordingly in the scorecard. Don't forget your ABC, check vital sign, your MEALS chart, and has a bleeding settle, and estimate the blood loss, whether she needs IV access, okay, what are the sort of blood investigation that is required, and also justify why are you doing a full blood count. I'm looking for anemia. I'm looking at the hemoglobin level. Why are you doing a coagulation disorder? So you want to rule out any possibility of any blood dyscrasia or any hematological disorder. Okay, so you have to justify at every step in order for you to show that you are competent, you are mature in terms of your thinking, for you to go through and pass this station, and IV fluids and all this supportive treatment that you'll be giving. Okay. Again, differential diagnosis may be discussed as part of the technical skill component and complex decision making. So you will be discussing what are the sort of your differential diagnosis that you're thinking about: placenta previa abruption, vasa previa, so on and so forth. So again, management will depend on the cost. So that's a very important sentence for you to be telling that to the examiner or the actor or actresses in the station. So for example, if we think that the diagnosis is placenta previa, so then what makes you say that? Okay, what makes your diagnosis being supported by your history from the initial part of it? Because you have checked that she had previous ultrasound that was done at 20 weeks and it shows low-lying placenta. Therefore, this is a possible possible case of placenta previa. So what are the risk factors of placenta previa? As we all know from our applied clinical knowledge, smoking, IVF, previous uterine surgery or instrumentation could also contribute to this condition of placenta previa. whether she needs to be admitted or whether she requires observation. So that's something to be considered, and that's case-to-case basis again. Antenatal corticosteroids, if it's appropriate for gestation. Hemodynamic, if there's a hemodynamical instability or fetal compromise, of course, you need to expedite delivery. Again, that has to be illustrated to the examiner because that shows that you are a safe clinician. You know what you're thinking and you know what you're doing. So again, to add up and sum up, and then the considering delivery between 34 to 36 and 6, if it's asymptomatic, and if it's uncomplicated placenta previa, then you will consider delivery between 36 to 37. So that's the applied clinical knowledge that's being tested here.
Correct, but this is a very difficult part. I know that students are so scared of these articles and this audit, Chin, and Chin is going to tell you exactly that how you have to master this. What are the tips, Chin? Just give them a glimpse.
So good point about this is that as a coordinator for medical audit in my hospital, so that put me at the advantage of doing these sessions with all of you in a live session, because we will be going through the RCT, the test accuracy study, systemic analysis, meta-analysis, patient information leaflet, which is something very, very common in our clinical practice, and also going through audits.
Yeah.
Okay. So again, very important question to ask about ourselves when we're appraising any sort of article or literature. We always check whether, whether these studies or methods that were used are sound, whether they are valid, and is there any importance, and what is the statistical significance in our clinical practice, and how do we apply this to our patient? Okay. So again, we will be using this IMRAD structure throughout our course module. So what does IMRAD stand for? I is introduction, M is methods, R results, A abstract, and then discussion. So if we use this kind of flow, we will not be stuck when we are faced with something that is usually we think that it's very challenging and we don't like to critically appraise because we don't do this often. So they are, again, very much like Dr. Sidra Ali said, like, in terms of breaking bad news, there's certain sentences and buzzword lines that you need to use in the exam. So very much similar in the critical appraisal of medical literature, you will be using the very similar pattern. We will have some sentences for you to be remembering, to bring that with you to the examination hall, so that you will be able to ace and score in the exam. So like, for example, in the introduction part of any literature, you always will open up by saying that I would like to present the appraisal finding of this article, mention the first author and colleagues published in which journal, in which year of publication, on the subject matter of the paper, and I will summarize the appraisal finding, highlighting the study's strengths and weaknesses, and conclude with my interpretation of finding in terms of the implication for clinical practice and for research. And for the recommendation at the very end, before you close any sort of conclusion or your station, so you would like to always reflect this literature again, whether this is a high quality study that shows substantial reduction in preeclampsia, for example, and perinatal death, and the finding that's consistent with other study on this subject. I will recommend this sort of therapy of treatment women at risk of, for example, preeclampsia, which is the clinical implication, and the further research may be required to examine the role of aspirin in other high-risk groups, such as those with renal disease. So that's the research implication. Okay.
Perfect. Perfect. What I would like to say is that I know that this is weakness of many of the students out there. And out of complete 9 stations, if they're asking about something, or if they're worried about something, is this critical appraisal or learning to read a research article. Of course, it's a challenge to read in 10 minutes. Chin is going to guide you that how you have to scan it perfectly, what exactly is needed to learn, what exactly is needed to pick out of that article, and how you have to present. Because at the end, what you're saying in 10 minutes is what matters. So what you're understanding is like the first step, but what you're saying is what matters, and that is what you're going to practice, because we know that it's an essential part of the Osce station, and you're going to be tested from that. Hats off. Thank you very much, Chin. Thank you. All right, friends. So last time we had 100% EFOG-Osce result. It was online. Students, they had spectacular results, all of them. I remember Angelica, I remember Sarah, my Malta students, Europe country students, they all managed to pass. Remember, I don't say that exam is easy, but I would definitely like to tell you that as compared to MRCOT Part 3 Osce, chances of passing is a little higher because it's an upcoming thing. The competition is less as compared to that. There, it's like too much of saturation. There, the things are difficult. Even a very good standard of a student, unfortunately, because of bad luck, cannot make. Here, I would like you all to start with more motivation and positivity, that if you're going to work hard and be in the upper strata of the students, definitely success would be yours. Now, another thing before I take question and answers, students, they keep on asking, why are we taking this EFOG? So what are the benefits of that? This Osce you have to take because you people have taken the EFOG-1, right? So this is a part and parcel to complete this. However, there are certain new directions and new horizons that it opens up, which Chin and Camelia can guide you further on. Yes, Chin. Yes, Camelia.
Yeah. So the EFOG degree, basically, it opens you up to about 28 to 30 member country in the European Union. So United Kingdom is still one of it, basically. So basically, by having this prestigious degree, you will be opening up yourself. For example, for myself, because I'm interested in fetal medicine and maternal medicine. So you can link in directly with the European Association of Perinatal Medicine and write to the hospital, which is actually listed on the EBCOG website for a fellowship training. So
now your hospital is also accredited, right?
Yeah, the hospital that we're working in has been recently accredited with EBCOG. So we are opening up the hub in the European Union site as a fetal, hopefully in the next 1 or 2 years, we'll be opening up as a fetal medicine training center around this region as well. Yeah.
And what about that Escher thing, Camelia? We had students who were asking about that, you remember?
Yeah, so after they obtain this EBCOG, after they pass this, there is an opportunity for them. If they have interest in fertility or reproductive medicine, and they have training in that for 2 years, then they also offer this European Fellowship in Productive Medicine. This is a different exam that they have to take to substitute for fertility and reproductive medicine.
Yeah, so basically students, they can have different opportunities after this. So this is like the first step, and that gives them a doorway. It opens up for them whatever field they want to take as a fellowship. They can just proceed further, right? Yeah. Now, the second thing before I take the question and answer session, I do know that many of our students, they are from MRCOG. They took from thrice of us through RFA, the EFOG-1, and we had tremendous the results were really well. They were actually in the EFOG-1 batch. Many of them who got the seat, they all managed to pass in the EFOG-1. We enjoyed and we celebrated, but now because many of them, they are in MRCOT and MRCPI as well. So they are comparing that, ma'am, how do we compare this? So I would like to tell you that MRCOG is quite different in terms of the paper format. The exam is going to be different in terms of requirement. Like article is not mandatory. In 2 to 3 exams, it was there, but it's not like 100% part of the pattern. Similarly, there the modules are being discussed. So out of that module, structure discussion or simulated patient task is there. We have got 14 stations. So out of 14 stations, we need to have 4 structure discussions which are fixed, but it's not obvious that it has to be from the basic skills or the complex skills, or for that matter, it has to be communication testing. So the format and the paper preparation is different. Of course, the obstetrics and gynecology, that remains almost the same with few differences in the EFOG recommendations, but rest, it's almost the same, but the pattern is different. We don't have any long case here as we have in MRCPI. The circuit is there, but the pattern and the format of the circuit, which we try to emphasize today, this is different as compared to others, right? Would you like to add in something, Chin? Hello, Chin, are you there? Yes.
Yeah. So again, yeah, like what Dr. Sidra Ali has said, yes, very different in terms of we don't have a medical literature appraiser in EBCOG, pretty much the same. MRCOG, again, 14 station versus the 10 station that we have EBCOG. For MRCPI, again, we have long cases, one long case, sorry, and then 7 active station. So I suppose it's just a difference of kind of format, really. But 70, again, like what Dr. Sidra Ali always said, like 70 to 80% of the preparation will still be somewhat similar in all across the 3 colleges.
So many of you are already in the study group, but the ones who want to join, the payment link is given on the website for the EFOG-Osce, and all the details are being given. The schedule of the sessions and the distribution according to the dates, that's going to be provided in the group. And all of you, for the next 24 hours, you can use the coupon OFF100. This OFF100, you're going to put in the got a coupon section, and that's going to reduce from $499 USD to $399 USD. That's going to be for 24 hours, but the premium students who were in the course, they definitely have this coupon. You all know that. So that's not a limitation for you guys. The paid students of EFOG-1, they are going to come directly, and they know that what is their details and their coupon as well, right? So we want you all to study hard. We want you all to stay positive, strive with motivation, and definitely the success is going to be yours. We are happy to take the questions which you people have regarding the preparation. Sheila had been messaging. Ahmed Kamal had lots of questions. Yes, please. All of you, you can unmute yourself or you can write in the chat box. Trisafas are here to answer your questions, and we are happy to take this, please. One by one. Yes, please. All right, Humaira. I know, Humaira, it's a challenge for you. There are few students, Chin, who are taking MRCOG 2 November as well, January as well, and November EFOG-Osce. So they are with me in my MRCOG 2 course as well. So definitely the pattern is going to be a little different, but nevertheless, because of the country, because of requirements, I think the earlier you people take, the better it is, as we discussed. The gap is going to make definitely the theory part volatile and a foggy memory that adds on to stress, right? Okay, Ahmed, any question, please? Ahmed Kamal, Sheila, my dear, Claire? All right, Saso, where are you? Okay, thank you very much. Thank you. All right. Yes, please, you people can unmute if any question is there, and you people can write in the chat as well. Anything not clear about the preparation? Did you people understand that how the themes are going to be? Sheila, can you compare it to MRCOG now, my dear, because you're with me in MRCOG 3 as well? Yes? Okay, perfect.
Yes,
Claire, okay. Did you understand the basic skills and the complex and all the details?
yes, ma'am.
Okay, that's perfect, my dear. I think Sasu is on duty.
Will there be mocks included?
Yeah, we are going to decide that in the paid group. Yes, it's going to be there, and we are going to try all the simulation so that you people actually feel near to exam. Okay.
Okay.
All right. We are going
Thank
to
you so much, ma'am.
Thank you so much, my dearest. Thank you. All right. So Ahmed is saying it's all fine. Humaira, are you clear about the paper pattern? Because it's going to be your first OSCE, so definitely we are going to speak more, Humaira. Right? All right. Okay. Thank you. So any other question, please? Okay. Archana, my dear. Archana Anand, Claire? Tahira, are you clear about this, my dear? Yeah? Any questions?
Yeah, Dr. Sidra, it's clear. Thank you.
Okay, that's perfect, my dear. Thank you so much. Thank you. All right, friends. So do we have any questions further? Okay, that's great. All right. So all those who couldn't attend the session, the video would be uploaded and you people can get it on your website as well. Saso, I can understand you're on duty and I knew the list of questions which you wanted to post. It's okay. I can understand. So no worries. You can put that in the WhatsApp group and we all are here to answer. Okay. in the paid group, you can put the questions. All right. Thank you very much, Tahira. You're also there. So you people can put the questions there. Later on, once we'll start studying, the practice is going to be focused as per the themes. And thank you very much, despite being busy. From the hospital, you people are joining. That means a lot to us. Thank you so much. So thank you, Chin.
Dr.
Thank you, community. Yes, my dear. Yeah, please.
Yeah, Dr. Siddha, may I know the schedule of the sessions so I can adjust my duties? Yeah.
As per the dates you want or the
Yeah,
themes?
yeah.
Dates? Yeah,
Dates, yeah.
Tyra, I'll give you the dates. Don't worry.
Okay,
It's just
thank you
been
very much.
given
Thank you.
now. We are going to have 3 months. It's going to be August, September, and October, right?
Yeah,
And November,
yeah.
we are going to have mocks. All right.
Yeah.
Okay. Thank
Thank
you
you
very
very
much,
much.
Tahira, my
Thank
dear. Thank you. All right. Thank you very much, Archana. Always lovely seeing your name. Give my regards to Anand as well. You are a family. Thank you so much. All right. Thank you very much, Jin. And thank you, Camelia.
Thank you, everyone.
All right, friends. Best of luck from the entire team of RFA Tutors. That was lovely having another series of Know Your Exam. I hope you're clear about EFOG, Osce now. Any questions, any queries, any concern? Team is right here, available for you 24/7. Love you all. Take very good care of yourself. See you guys in the study group with all the questions, with all the practice, and let's make it a success together. Bye-bye from our side. Take very good care. See you guys. Bye-bye from the entire team of RFA Tutors. Thank you.
Thank you.
Thank you. Bye-bye.
Bye.
Bye-bye. Thank you.